Hi, everyone. We are getting ready for the Research Roundtable, and we want to welcome you because it's going to be a fantastic conversation today. We have Dr. David Amron that will be joining us. He is logging on any second. And in the meantime, Dr. Herbst, we're talking about fibrosis with Dr. Amron. And what was your interest in having him on? I know that you collaborate together all the time.
So I've always been fascinated by the fact that there is fibrosis in lipedema tissue, and we've known about it for years. But I think what's really important is to get the perspective of somebody who does lipedema reduction surgery and actually is in the tissue and has, I think, a better understanding of the fibrosis in women with lipedema. And that's why I invited David on today.
And we're so glad to have you. And we want to welcome everybody that's logged on. We already have over 40 people that joined us, and we want to thank you. Let us know in chat where you are logging on from. And we're so glad you're here. We will do questions and answers at the end of the program. Dr. Amron is a board certified dermatologic surgeon with over 30 years of expertise and is internationally recognized as a leading expert in lipedema, liposculpture, and revision liposuction. He has dedicated his career to pioneering advancements in lipedema reduction surgery and is the founder and medical director of the Roxbury Institute, which has locations in Beverly Hills, Tucson, Salt Lake City. I see, Dr. Herbst, you've got your Roxbury Institute shirt on there.
I do.
Look, I guess I didn't get the memo. I get, well, of course, I don't work for the Roxbury Institute.
We've got you sandwiched. It's an
I
Oreo. You're the pre.
I'm an Oreo cookie here and it's all good. But you know what's so interesting? I love this in your bio, Dr. Amron. You have developed the Advanced Lipedema Treatment Program, which is at the forefront of surgical innovation. And it's uniquely suited to addressing the dense fibrotic fat tissue associated with lipedema. And when we said, what do you want to talk about tonight? You said fibrosis. So here we go. Now, as is the case, I will disappear while you two have an amazing conversation.
Oh, wait, I'm not sure about that. You're disappearing, leaving me and Karen alone?
Yes.
Put it out?
But
That's dangerous.
if you misbehave, I will come back.
Yeah, I think we're gonna need you here. Because
I am always
it's always a very spirited conversation, except usually I think I'm usually interviewing you, Karen. This is the other way around, right?
This is the other way around. Yeah.
I'm a little more nervous about this, I gotta tell you.
You're in the hot seat.
All right, well, I'm buckling my seatbelts. So is everybody else. We'll get to the Q&A as soon as you guys do your thing. And I am disappearing, but I'll be lurking in the shadows. Have a great conversation.
Brennan.
And thanks
Thank you.
everybody for
Good-
joining us.
Good seeing you.
You
I'm gonna
too.
start by saying, Karen, I just got back from Italy last night. So
my
I'm
gosh.
incredibly jet lagged. To tell
Oh my
you.
God, perfect. It's just gonna
Yeah,
pour.
and so you're gonna hit me with all these tough questions here.
No, I was doing some research on fibrosis just today, just to see if there was anything like that I needed to figure out. And there's a lot. There's just so much stuff out there, but a lot of what I'm reading is related to non-lipedema obesity. And so they talk about abdominal obesity, fatty liver disease, cardiovascular disease, and it's not lipedema, where at least early on before non-lipedema obesity sets in, it's a different kind of fat tissue. It's in a different location and it's more insulin sensitive. So I guess before we start, I really think it's important for us to just define what is fibrosis. Do you have a definition that you favor?
Boy, let me pull out Webster's here because sometimes I'll take the most simple words and really try to make sure I'm accurate. I think of fibrosis as basically scar tissue, and I know again that's a layperson's term that has occurred from chronic inflammation.
I agree with that. And that's how I explain it to people, that it's like having a scar in your fat tissue, but in in a diffuse area, right? Would you agree with that? It's pretty diffuse in lipedema tissue, the fibrosis.
Yeah, I think it's all over the place in varying degrees. And I think that areas that are more prone to congestion or from hydrostatic pressure will tend to have more fibrosis.
So what areas would you say, just off the top of your head, are very, like areas that you classically see fibrosis? Where you look for it typically?
Well, I think that, first of all, I thought, we could start by talking about the process of lipedema, to make sure we're on the same page with things, like what's going on. And then we can,
Sure.
talk about different types of fibrosis and how we see it. But, to quickly answer your question, I would say that in most patients with lipedema, if you look um, more distally, especially like the calves, the lower calf and ankle area, you can tend to see fibrosis more in the lower part of the calf and ankle unit, around the ankles. Again, it tends to hover more around the knee area, more fibrosis there, and less so in the upper thigh area. Some patients will tend to have quite a bit of fibrosis around the pelvic girdle unit. Um, but it really varies. Some patients, as you and I both know, we've seen quite a bit of fibrosis even in the central upper abdominal area, the inframammary region. I think
Hmm.
that the back part of the arm, especially towards the elbow, tends to be a hot area of fibrosis. Tends to hover more around joints, right?
Hmm.
There's more fibrosis around joints.
And I think your point about the hydrostatic pressure, we know that when you stand, the highest amount of pressure in your vasculature is in your calves. And you mentioned that you get a lot of fibrosis in the ankle. And I think, one of the things about calves of women with lipedema, and we can go back and talk a little bit more about lipedema just to set a little bit more of the stage, but the calves tend to be really firm and thick, and you can't get your finger into the tissue. And
Yeah,
yeah, we
yeah.
we just submitted a paper for publication where we showed that even in early stage lipedema, there's more fat on the calf, and that's across the board, but not on the knee. So that, I wonder if that fibrosis buildup is reflecting the long-standing amount of time that the fat has been there on the calf too.
But again, it depends. I think if we're talking about like type 3 versus type 2. So when you say that the calves tend to have, more fat than other areas early on in type
Mhm.
2 lipedema, that tends to stop at the knees. You don't see the calf involvement many times until years later as what I call secondary involvement. As you probably know, because we work together, I now talk about primary areas of involvement and
Mhm.
secondary areas of involvement. So in a type 2 patient, the primary areas will be the hip and pelvic girdle region down to the knees. Many of those
Mhm.
patients, their calves and ankles are quite thin initially, and later on they become more involved secondarily. And this is where the insurance companies, we've had to kind of train them, because many times they would look at a type 2 patient, not a stage 2, a type 2 patient, and say that's not lipedema because their calves and ankles are not involved.
Mhm. I agree with you. However, I think the type 2 is the more, it's not seen as much as the type 3.
True.
And when we examined the legs of women with lipedema, it was just clinically, I said, is there fat covering the shin or not? Yes or no. That was it. It may be a thin layer, and maybe there's a lot more on the thigh, but it's still there. And again, it was present in women with stage 1, so they have less fat generally than women with stage 2 or 3. So
Mhm.
it's just kind of an interesting finding. It needs to be replicated by somebody else, but I think it's giving us a hint that even in the different types, that there's something going on in those calves very early on, and it may be subtle, but it's there.
Yeah, and it's true. Emily Eicher, we both know very
Mhm.
well and love dearly, taught me something years ago, that many times one of the earliest signs you're going to see in lipedema is the lateral ankle puffiness and swelling with things. You've seen that in patients, that lateral ankle puffiness. Sometimes you don't see even much fullness of the calves yet, but you see that puffiness there around puberty. And so
Mhm.
something is going on
In
in
my
the
opinion,
ankle
that's a
area.
little bit of compartment syndrome where fat grows around
Mm,
that small saphenous vein and it
mm,
squeegees the fluid down and around that lateral ankle where that vein begins.
mm.
And
Interesting.
you don't see reflux in the vein, and they go to a vein specialist, and the vein specialist says your veins are fine, and they are in the sense that they're not refluxing to a point where you would treat them, but they've still got fat growing around them, and that's a question I meant to write down for you, is that where do you want to set the stage for lipedema? We're kind of deep in here, but do you want to go back and backtrack a little bit? You wanted to say something
Yeah,
about
what I think is, we've talked about this. Remember, in Germany, I stood up and you said, can I just kind of run through what I think is going on with lipedema? And we did it again at, I think, a webinar that I was leading a month
Mhm.
ago. And, it's an interesting area to start with in what is going on with lipedema. Or, another way to look at it is when you talk about pretibial fat that we see in lipedema that is, more unique to lipedema, how did the fat even get there? It's a
Right.
really interesting thing. How did that fat get in the pretibial area? Because we're sort of taught early on, like you grow up with this, you're born with a certain number of fat cells that expand and contract. So it always perplexed me, how did that fat get there? And so I went on through my understanding because you checked me on this last time we talked about one part of it. Um, and that's why I want to talk about lipedema as being a process, that's
Mhm.
going on. It's not just about the fat. It's not only the fat. It's a process that's going on. And it's not like cancer. If you don't take care of every little thing, like it's just necessarily going to come back. It's a process that's going on with it.
Yeah,
And
I think that's
so,
a great way to describe it.
yeah, it's a
Better.
multi-system process that's going on. I think and I've said this, I remember, to you for over 10 years. I think we'll find that the initial thing with lipedema is a defect of connective tissue. The initial thing that you're inheriting a defect of connective tissue. Is it a weakness, a lack of integrity of connective tissue that we're seeing across the board in lipedema with patients with other aspects of it, and leaky gut syndrome and Ehlers-Danlos and the hypermobility with it? I mean, why is it that all these commonalities of weakness of connective tissue? So
Mhm.
I said to you that in 2016, I remember that there was evidence showing that there's movement of fluid across lymphatic membranes.
Mhm. Yeah, leaky lymphatics, you
Leaky
said.
lymphatics, but I remember the last time you said it hasn't been proven yet that
Yeah, I
it's
don't
leaky
think so.
lymphatics. Okay.
But I did add that Eva Sevic taught me, and Eva Sevic's from UT Houston, and she'll be on with us, I think, in September. But she said, Karen, if you have leaky blood vessels, you have leaky lymphatics. Same thing.
I think that's true. I think you've got leakiness and, that's why the increased bruisability also with it. You've got leakiness of connective tissue. You've got movement of things, leaky blood vessels, leaky lymphatics, leaky vasculature. So how do those fat cells get to the pretibial region? What initially perplexed me, it didn't get there from, the blood moving things, I don't think. I think it's a migration across membranes. And so you've got early cells moving from the intravascular lymphatic or vasculature into the extracellular tissue. Let's call them stem cells, I guess.
Mm-hmm.
They, I think that they're finding themselves in the environment of other fat cells. They begin to differentiate into earlier fat cells that begin replicating mitotically. Has that been shown?
Yeah, well, yes, they've shown that the stem cells from lipedema patients have a higher replicative activity. And
Okay.
that was, yes, a number of
Yeah.
labs have shown that.
Yeah. And then so the swelling is a first initial thing that we're seeing with lipedema.
Mm.
The movement of fluid across membranes is the swelling. That's why we know that patients that are getting swelling is one of the initial concerning things, because
Mhm.
that swelling can lead to the development of the fat cells,
Agree.
And then the inflammation happens later on. Now, why is inflammation happening? Is it is there dying off of fat cells that are going on, which is what I thought or heard because of hydropic degeneration? They're not keeping up with their mitotic rate. And
I
there's
don't think that's universally understood. I know that when we look at early stage lipedema, there are no crown-like structures or necrotic fat cells. When you get into later stages, you find them. And Professor Chinti showed in his when he was doing electron microscopy that there were no crown-like structures. I think only one person had one crown-like structure. So I don't think it's necrosis early on.
yeah.
Yeah.
Okay. So that's interesting. So so my understanding, it's a mixed cell infiltrate going on with the inflammation, but it's more a preponderance of
Great.
macrophages.
Yes.
Okay. But in any sense, there's inflammation going on.
Yes.
Is the inflammation an autoimmune type of inflammation?
I think that's a fabulous question. I really do. And nobody has
Yeah.
made that connection yet, but it may happen someday, but I don't know for sure yet. But I'm kind of curious, do you think like a young girl in puberty that she first has swelling or does she grow fat? Like what comes first, the chicken or the egg?
I think it's swelling first. I
Okay.
do. I think the first thing we're seeing is the swelling. I don't think there's just growth of fat initially. I could be wrong. I just don't think it's initially growth of fat.
Yeah.
So anyway, we got chronic inflammation. It is an interesting thing. Is it autoimmune? I kind of think maybe it isn't. There's no specific antigen like in other autoimmune conditions like lupus or other autoimmune things. We're looking for an antigen specifically. I think it's just inflammation that is cleaning up debris or
That's what, yeah,
necrotic debris.
I would agree that there definitely is debris cleanup.
And then, okay, so you got chronic inflammation, and that leads to scar tissue and fibrosis.
Mhm.
And
And
then it gets kind of walled off, and that walls things off more, and there's more death and more inflammation and more fibrosis, and this kind of sort of vicious cycle goes on with it.
yep,
And then, so that's what I think is
that
going on with,
creates that kind of web and
yeah,
then you got poor blood flow in and poor
right.
lymph flow out, right?
Right. And more poor lymph flow out, more congestion going on with things affecting
Mhm.
lymph flow out with it.
Yep,
So that's what I think is really going on, the process of it. And we talked about, later on, because, you're an endocrinologist, that, that those cells are very kind of metabolically active because they're closer to younger
hmm
cells.
hmm
And at
yep.
some point, it begins to negatively impact one's metabolism.
I think so.
Yeah.
And I think that increases the risks of developing obesity.
Yeah.
So,
Yeah.
you mentioned fibroblasts.
No, I
We
do.
never talk about fibroblasts and lipedema, do we ever?
We don't. We don't. I think that's a whole important area of research that
Yeah,
needs to
because
go on.
nobody's really studying that
Yeah,
that I know of fibroblasts and lipedema. I should look again,
I
but I
think
haven't seen it.
I feel like we somehow talked to Bruno about that, looking at fibroblasts and it's a whole, Bruno of UCLA, Bruno Paulton. I think
Yep.
it's a whole important area to look at, which kind of brings up the other thing about, patterns of fibrosis as I've kind of like talked about this thing. And maybe I've talked about it more because I'm kind of in there dealing with
Right.
this thing and seeing it, even though I'm not like, doing testing for it but I see these patterns of fibrosis with lipedema. Um, and as we know, there's nodules in many patients. There's a nodular pattern. There a lot of patients have more of a strandy pattern of fibrosis, like a web-like network. And some patients have more of that and really very little or no nodules per se. And those
Mm-hmm.
patients, I think we've agreed, tend to be more the swellers, that kind of
Ones that have the strandy.
that looser strandy pattern of fibrosis. Then you've got some patients who get this dense fibrotic pattern that is almost like cement. It's not really nodular, it's not strandy, it's a dense pattern. I've kind
Mm-hmm.
of said and argued that that pattern is the most concerning pattern in terms of its effects potentially on lipolymphedema and damaging lymphatics. The strandy pattern doesn't seem to damage lymphatics as much as you kind of expect it because it's more of a loose pattern of swelling. It's a dense pattern. And then there's a final pattern that I see, Karen, that is what I call a granular pattern. They're almost literally like grains of sand. They're
Mm-hmm.
almost like little grains of silica in a way. And that pattern, from what I've seen, tends to occur more in the subdermal layer, right under the dermis. And I think that pattern actually is clinging more to lymphatic capillaries.
Yeah.
And in my experience, those patients are the ones more so that have that real tenderness to pressure that commonly goes on with lipedema. I've seen a lot of even early stage 1 patients, that granular pattern, that before the surgery, they'll say, I'm stage 1, but I'm so sensitive to touch and pressure. And I get in there and it's sure enough, that granular pattern that's clinging underneath it. And I think that kind of makes sense because it's probably having inflammation in the subdermal area that we know is full of sensory neurons transmitting pain. So I think those patients, that granular pattern is its own kind of thing going on with it. And of course, there's mixtures of things. You can't just say it's only one pattern, but it's not
Mm-hmm.
only nodules with lipedema, there's other patterns. And what I've also noticed is that pattern, this is why we got to look at this stuff. I've seen that pattern of fibrosis tends to run across generations. Like I've said, if I do a grandmother, a mother, a daughter, generally you see
Mm-hmm.
the same type of pattern of fibrosis.
That's very interesting. I think you should write this up.
We should write this up. Yeah,
Yeah.
yeah,
Um,
very.
so you're going to encounter some type of fibrosis when you perform lipedema reduction surgery. What advice can you give women to improve their tissue prior to seeing you that might be helpful, or is that even necessary?
Well, I get asked that question a lot. I think literally 3 patients today asked that question about things, and then
Okay.
pre-ops that's asked. And it's a really good question. What can I do, if anything, before surgery to improve either, the success of things or recovery? And I think that it depends on the type of patient. I think that many, okay, so certainly, patients should be on respectful dietary strategies. I mean, it's one thing I tell every patient right away, just begin to understand respectful strategies. And that's a whole big area of itself that we're not going to talk about probably much today. So,
Mm-hmm.
Just get on that right away because it's important for prevention. It's important certainly after surgery the rest of your life. After that, I think that you then begin to look at each patient a little bit differently with things like that. I think that the patients that have are uncomplicated, like your uncomplicated, like average stage 2 patient, maybe even early stage 3 or stage 1, I don't think that they should continue with their compression therapy, compression garments and things they're doing, maybe intermittent MLD therapy, but there isn't any specific protocol I tell those patients they've got to be starting on right away with it. Like, maybe pump therapy or bandaging and wrapping, but that would apply to your more advanced patients. So if I see a patient that is really very fibrotic, very tense, has a lot of congestion, stage 3 patients, certainly patients with lipolymphedema, those patients it's very important to start pre-compression therapy on. I think pre-compression pump therapy, I know we're here with Lympha Press today, but those patients, I think pump therapy is really vital. So we write them for pumps. We have them beginning pump therapy with things prior to surgery, bandaging and wrapping possibly. in those patients to really move fluid along with a qualified lymphatic therapist is important. But I'll say this still, because I know that LymphaPress is hosting this and part of this. I do think that we write every patient now prior to surgery for pump therapy. I think it's I believe in the benefits of it. I think it's important to move fluid along, and this is the important thing. After surgery, you can't predict which patients absolutely have to have it because there are some patients that become very congested. I call them delayed decongestors. And that's another interesting area. Why are some patients, there's so much inflammation after the surgeries with things. They get very congested, and a pump is vital for those patients. Maybe those patients have MCAS. Maybe those patients that become very congested after surgery are the ones that really should have been screened for MCAS prior to surgery.
And that's not as easy as we wish it was.
No, it's not.
Yeah, a lot of the women that I'm sure have mast cell issues test negative, and that's because mast cells secrete their mediators into the tissue, and you hope some
Yeah.
of it trickles into the blood. So right at that moment that you're getting your blood drawn, you find that mediator, or you do your 24-hour urine collection, which tends to be, I think, a little bit more successful. But I
Yeah.
think, you're touching on the fact that there's different ways that you can exacerbate the inflammation associated with lipedema, and mast cell issues are one of them. And, if you think about, there's a Swiss study that came out saying about 86.2% of women with lipedema have some sort of chronic vein disease. And there is fat that grows around veins. We all know that there's perivascular fat tissue that helps feed the vein and talks back and forth to the vein. And do you think that if somebody had, and we don't understand small vessel disease, right? Really, small vein disease, who's studying small vein disease? So it could be that there's a lot of small vessel disease, like small lymphatic vessel disease, small blood vessel disease, and the fat that's growing around them is becoming fibrotic over time. And that might be what your strandy pattern.
Mhm.
And I can actually, I believe in some women with lipedema that I can see that stranding pattern on thermography.
Yeah. Yeah.
And that would be cool if you guys had a thermal camera in your clinic and
We
you
we
could
talked about that. Yeah. Good.
somehow correlate it to, you may see nothing. I mean, sometimes I just see one large vein or something, and it's not very long in one spot. But then that gives you information that you're not seeing anything but one vein, and
Hmm.
maybe they're very
Yeah.
congested in that area. It would just
Yeah.
be fun to get like a medical student on that.
Yeah. Yeah. So, to finish answering your question about preparatory stuff prior to surgery, we talked about the compression stuff. Um, dare we start talking about GLP-1s here, Karen?
Yeah, go
You and I?
please.
Well,
Yes.
you and I have this thing about the GLP-1s, and I call it the chicken and egg type of thing. I know you um, feel very strongly about their potential use in lipedema patients, and I think that they also have a lot of promise in lipedema patients. I think that there is especially a subset of patients who really benefit from it immensely in terms of reducing inflammation, and not just simply for weight loss. Um, but I think that certain patients, it's very important to start GLP-1s prior to surgery. This is
Hmm.
where we started working together in the Diagnostic and Preventive Center and targeting patients that really need to be calmed down their inflammation prior to
Hmm.
surgery and begin a GLP-1 agonist. I think that patients that are has less inflammation, your average patient, it's not as important to be considering a GLP-1 prior to surgery, and not specifically for weight loss only. Those patients I like to really consider GLP-1s possibly after surgery. I want to decongest them and make the improvements with surgery and do it afterwards. But,
Hmm.
prior to surgery, we talked about preparatory stuff. Some patients really do need a GLP-1 prior to surgery.
Hmm. Yeah, I agree. I think it's good to try, other conservative therapies prior to that. And I think it's also important to try and microdose it, just to try and
That's
keep the level as low as possible, but yet get the biggest bang for your buck, because they're potent medications. I mean,
yeah,
they're medications.
I think microdosing is going to be the next frontier in GLP-1s. I think it's a hugely promising area with things. I think that I'm sorry, I'm just adjusting this because literally as we're talking, I look at myself and I'm getting redder and redder, and I'm a little sunburned from my trip, but the sun is coming in through my window, and it's almost blinding me here.
Yeah, I see you are getting red. So, let's go to some questions. I think there's a lot, and I think it'd be good to include our audience.
Yes,
So let's see if I can. I This is just kind of coming back to the skin issue, and you are a dermatologist, Dr. Amron. What are the potential side effects using Vaser with someone who has thinning skin?
thinning skin. Well, I think with lipedema, we're dealing with patients who don't have the same integrity in general as other patients. If we go back to it being a connective tissue weakness, many of these patients have not only hypermobility of joints, but kind of hypermobility of their skin along with things too. So it's a common thing we deal with lipedema patients, skin that doesn't have perfect integrity. And yeah, as we all age, then skin tends to get thinner, so you're dealing with that also. I don't think Vaser is problematic at all in terms of dealing with just necessarily thin skin. Vaser's ultrasound energy, it is an energy-based device, and when used appropriately, I don't see any issues in terms of thin skin with things with Vaser.
Okay.
And I
This
don't, I
is
don't see any contraindication in using Vaser on patients with thin skin.
good. This is coming back to you. You were kind of theorizing on how the inflammation and fibrosis happens, and you did mention leaky gut. Victoria Bowden asked, is there a connection or relationship between lipedema and leaky gut?
Um, all I can say is I think that it's a connective tissue weakness and that there is a high proportion of patients with lipedema that also have leaky gut syndrome. I don't know what that percentage is. Maybe you
Hmm.
know that more than I do, have actually truly diagnosed with leaky gut. But I think that when I've said this, that many specialists that see patients with certain things, they should automatically be screened for lipedema.
Hmm.
And maybe leaky gut should be one of those things. Maybe a gastroenterologist who's seeing patients or diagnosing with leaky gut, they should suspect lipedema. Problem is most of them don't know about lipedema, but yeah, there's definitely an association. Your thoughts, Karen?
Yeah, I think so too. There, Phil Scher published that hypothesis paper saying that he thinks that lipedema kind of is like pregnancy. And in pregnancy, the intestinal lining breaks down a little bit and allows pieces of bacteria across, including
Mm,
lipopolysaccharide, and that kind of sets off
mm,
inflammation in the body. And then Jose Luis Simaro, who came up with the compartment syndrome hypothesis, thinks that it all comes from the leaky gut, and that inflammation that's within the vein compartment is originally from the gut. So I
mm.
do think we need more data, but I think, and it would be great if we could just test every woman to see if she has leaky gut.
Yeah, yeah.
Let's see.
We really should be doing that actually. Now that
Yeah,
you mentioned that, it's one of the areas that really should almost be screened. Do patients are having gut issues that have lipedema and vice versa?
yeah. And then there's mast cell too. Mast cell issues can, from mast cell, you can develop a leaky gut. So then the question becomes, you may have leaky gut, but what's it from? So
Yeah.
it's not as easy as a yes or no question, I think.
This is such a cool time for all of us,
It
that
is.
we're literally, it's just, where we are in terms of lipedema, in terms of, it's just such an amazing thing that we're involved in. And I just want to see it get better and better.
So this is kind of an off-topic question from Jackie Scherer, but she asked, where in LA can one have an ICG fluorescent lymphography or NIRFLE? And would these imaging studies be helpful when doing liposuction in one that has lipolymphedema?
So we're talking about doing lymphoscintigraphy, basically, right?
No,
No.
the ICG
Oh,
green.
IgG, God. You
Yeah,
know, I really I used to look at that stuff years ago, and I just realized it didn't change what I'm going to do necessarily therapeutically. So I always
right.
stopped using it as testing prior to surgery in really any patient. So I don't have an answer to it because I haven't looked into it for years and years.
Yeah, I know that it's still not available for most clinical practices.
Hmm.
The, the people who do have them tend to be surgeons who do microsurgery on the lymphatic system.
Hmm.
And I regularly order nuclear medicine lymphoscintigraphy scans, but I don't order ICG scans. So I think you could get a lymphoscintigraphy scan a lot easier than an ICG scan.
And
And then
and you're
if it was abnormal, we would send you to a microsurgeon who would do the ICG.
you're doing the lymphoscintigraphy to rule out or diagnose lipolymphedema?
Yes, when especially when I see asymmetry of the limbs,
Right.
or I'm very concerned that there's a lymphedema and they're going for surgery, and I want to make sure the surgeon knows that that they have a problem
Yeah,
in
I
lymph.
think that the most interesting use is when you see that asymmetry and trying to figure out what is going on. Is a
Yeah,
lymphatic issue going on, or is it a vein or vascular issue going on?
agreed. Mahdi Al-Yami asks, can fibrosis reduce with training in the gym or not?
I think kind of no. I think it's really hard, for when you got fibrosis set in the tissue, you got scar tissue there, that training in the gym and exercise is really going to make much of an impact on that fibrosis, of lipedema. I think that you're going to get further with dietary strategies to prevent further fibrosis. Maybe the GLP-1s, as we see in certain patients, can help reduce fibrosis. Um, you know, so no, I mean, ultimately to me, it's like that's where, as a surgeon, you go in and you do your work on things, and it's not just the liposuction removal of fat, it's how the surgeon has dealt with the fibrosis. And
Mhm.
that is such an important part of lipedema surgery. It's not about it's talked so much about the fat removal, how much fat removal, but how did the surgeon deal with the fibrosis?
Mhm.
It's not just what's in the canister and, oh, great, I removed 8 liters of fat or whatever it is, but was the fibrosis properly treated in the best way? And I actually would say that, we talked about this, you could almost, and I want this to be taken the wrong way in lipedema patients, but you could almost go in there, not necessarily remove fat, and treat all the fibrosis and get immense improvements in terms of symptomatology and decreased swelling and all that stuff with it. So
Yeah, I think that that is if anyone takes home anything from this conversation, it's that point right there, that it's not just a number in a canister, but it's the fact that the surgery itself has completely decongested that tissue. And
right.
then you need to wear your compression,
Right.
get your manual therapies, eat right, exercise right to let that tissue heal. I mean, basically you're giving it like a new start, right?
Yeah, you've improved the process again. That's where, this mentality like you've got to remove every single fat cell is like what lipedema surgery about. It's such a wrong way to look at things. If you left any fat cell behind, that's not what's going on, because you're improving the process of things with it. And the as important as the fat removal is the treatment of fibrosis with it. Because the
Mm-hmm.
fat, I go back to this, is not the real culprit in this thing. That's why, I've used the fat for years for fat transfer successfully without ever in one patient transferring the process, because the
Mm-hmm.
fat is
That's
not the fat
that's
are actually
important.
I view the fat in lipedema as more younger, I don't want to say healthier, but maybe they are healthier fat cells. They're just younger cells. They have
Mhm.
greater uh, ability to replicate, but they're younger, healthier fat cells that are closer to stem cells.
Mhm. I would say that, you know, if we look at if we use the lymphedema literature, if you look at an arm with lymphedema, it's patchy. There's some areas that have lymphedema, there's some areas that don't. And I think the same thing could be true in lipedema or lipedema, but that intermixed with those young cells, those young lipedema cells that you're talking about, if there's congestion, you're going to get some hypoxia, some inflammation, fibrosis, and some unhealthy fat cells mixed in. So when a woman with lipedema loses weight, she can lose some of the fat, but not all of the fat, right? And I'm not exactly sure what they lose. Because, you know, like in abdominal obesity, the more fibrosis you have, the less likely you are to lose fat after bariatric surgery. So what is being lost? You know, if you go to the gym and you change the food you eat and you are
Yeah.
able to lose weight, what is going away?
But see, that's a really interesting point right there. You said in bariatric surgery, the patients that have fibrosis are more unlikely to lose that fat. But I'm going to say that maybe a lot of those patients actually have lipedema, that they were not diagnosed. So you're saying in weight loss surgery,
That could be.
just in weight loss surgery, you're saying in patients that have more fibrosis in that area didn't lose fat in that area, but were they screened for lipedema? Because I think those
No,
people,
it was abdominal obesity. So these are
abdominal obesity, I think that those patients most likely have lipedema. And the bariatric
very well be.
surgeon didn't screen for it and missed it. Because I think so many patients that are getting bariatric evaluations or bariatric surgery have lipedema that's just undiagnosed.
Very possible. So here's a question from SB. I did not have lumpy calves until after a car accident in 2021. Can trauma make the tissue worse?
Well, trauma can kill off fat cells externally.
Mhm.
You can get fat necrosis, dying off fat cells by blunt injury. So trauma can kill off fat cells. Trauma can also cause scar tissue, creating unevenness with things. So just the trauma itself without lipedema can create lumpiness.
Mhm.
But
Mhm.
but then again, a person with lumpiness on their legs, especially both legs, should be screened for lipedema.
Mhm.
But did the trauma cause the lipedema? No. Lipedema is a genetic condition in a process that's developing. I don't think the trauma did not create the lipedema. It could potentially make the lipedema worse by creating more fibrosis or scar tissue from the trauma.
I agree. Yeah, agreed. So it's kind of like mast cell issues can make lipedema worse. Accident could make lipedema worse.
Yeah, right.
Anything that generates abnormal amounts of inflammation.
Yeah. Yeah. But I guess I was hearing that the question was, it seemed like did this trauma create potentially lipedema? I don't think the trauma created lipedema. Lipedema is something that the person genetically inherited, and maybe the trauma made it worse.
So so back to the GLP-1s, this is an anonymous attendee asking, when do you restart GLP-1 after surgery?
So if somebody's on GLP-1, they're going to stop it 2 weeks before the surgery. In our case, that's our protocol. And after their last surgery, um, they can restart it there's no real reason. Within a few weeks, they should be able to restart their GLP-1 agonist. Personally, I think that in most patients that are on GLP-1s that I move ahead with surgery, I do the surgeries, whether it's 2 or 3 surgeries, whatever it is, and then there's a period of evaluation to see how they're doing. I don't personally just start every single patient right back on their GLP-1 again.
Good. So in addition to GLP-1s, an anonymous attendee is asking, does metformin and or berberin help to reduce fibrosis? And do they work the same? And
I got to throw that back onto you, Karen, that question. This first,
so,
I don't use metformin in my practice because I'm more of a surgeon with things. I know you have more experience with it.
So I used to use metformin, and I still will use metformin, especially in women with polycystic ovarian syndrome. And berberin actually has less side effects than metformin, and some people consider it to be better than metformin. So I have used both. The problem is that I haven't seen the incredible changes in terms of reduction of weight, in terms of reduction of inflammation, just life-changing events in a woman with lipedema compared to a GLP-1. So I'm leaning more towards GLP-1s, but for those who can't tolerate GLP-1s or don't want a GLP-1, metformin and berberin also have been demonstrated to reduce fibrosis.
I have a question for you. Do you think that there's hope for oral GLP-1s?
Yeah, there are currently some oral GLP-1s. They're just not as effective, but
Right.
I think it's coming. And I
Right.
think we're going to see more and more combinations of peptides. And I also think the flip side of the coin that we haven't talked about is muscle. When you get all this fibrosis in the tissue, you're also affecting muscle. And sometimes when I do an ultrasound, I can't even see the interface between the fat and muscle because there's so much fat that's growing through. So I think it would be interesting for us to develop a program using peptides that improve muscle as well as reducing fat tissue. And that would be something that we should look into, but that's a
Yeah.
whole
I always remember
other talk.
your talk a few years ago at FDRS on lipedema fasciitis.
Yes, I
That
still
it's,
see that
yeah,
occasionally.
yeah,
Yep, especially in the IT band.
yeah.
So here's a great question for you from Sherry Husky. Is there a consensus in the US regarding whether or not lipedema can be present in the abdomen? And she said she feels nodules in her lower abdomen. And after a paniculectomy last year, her abdomen was very distended. And the therapists think it's related to surgery and that there could be blocked lymphatics. What do you think?
Well, yeah, I think I remember sitting with Stutz at one of these
Yep.
conferences many years ago. We're just sitting outside and just talking. Um, I remember him saying, I don't really know if I believe that lipedema occurs anywhere other than the extremities, the arms and legs. And I think we're beginning to really realize that it really can and does commonly occur outside the arms and legs. So, we know for sure the pelvic girdle is commonly involved in patients with lipedema. That hip upper buttock area as it goes around towards, the inguinal area in front as it wraps around. But I'm beginning to appreciate more and more that lipedema absolutely can involve the abdomen and not only abdomen, the torso area. I have a lot of patients that have lipedema around their waistline, the mid upper back area. Again, they're so incredibly fibrotic. I think that the patients that have type 2, and this is another study that we have to do, Karen, patients that have type 2, the triangular pattern of lipedema, are the ones that have a higher incidence of involvement secondarily in their torso area. The type 3 patients that have more of a column-like look without pelvic girdle involvement generally don't get involvement in their abdominal area with lipedema. But it's quite common. I think that, you're right. You have great fingers in terms of feeling it, and I think that we're really underestimating the amount of involvement of lifting the torso area. Now, that said, when I make a surgical plan for patients and I prioritize things, I try to talk to them that you don't have to absolutely do every single thing. Many times I will do their pelvic girdle and thighs and calves and maybe their arms. And their torso is really not so involved with things. I go, let's see what occurs after we do these first couple surgeries if your torso really needs to be done. Maybe they'll further respond to a GLP-1 agonist afterwards with things. But there's some patients that do need their torso surgery done with things, but
Mhm.
not necessarily every patient. So I don't want people out there hearing that every patient with lipedema now needs to be having their torso done.
Yep. So here's an interesting statement from Bethany Hengst. She's put a lot of comments in. It would be impossible to get to all of hers, but she said, the common belief is that fat precedes fibrosis, but doesn't Dr. Amron's statement that fibrosis removal has a greater impact on improved phenotype support the opposite, that fibrosis drives adipogenesis?
Boy, I have to, um,
So
I'm a little
instead of
jet lagged. I have a hard time following that. Can you,
Yeah, so what she's saying is that normally we think, oh, first you get more fat and then you
Mhm.
develop inflammation and fibrosis.
Mm,
But you remove the fibrosis and get such an incredible improvement in
mm.
lipedema. Would it then explain that more so that fibrosis drives the fat cells to grow?
I don't know about
Fibrosis comes first. Fibrosis comes first.
I don't think fibrosis comes first.
Okay.
I think again, I really think the swelling and the fat and the fibrosis then occurs at the end. But to me, when I'm doing the liposuction, yes, of course I'm removing fat. I'm not just saying I'm not removing fat, only treating fibrosis. But
Mhm.
I think it's just so important to treat the fibrosis because it decongests everything and begins to improve the flow. I also think that you are freeing up those kind of healthy fat cells in a way that are just surviving there because part of the death of them in inflammation is the trapping of them,
Yes, they're in
right? So
jail.
I actually you actually can release all that there in a lot of patients and coat
Mhm.
that skin with those healthy young fat cells, and
Mhm.
probably it's gonna be fine with things.
So why do you, so Edwina Sampler Wright says, why does fibrosis hurt so bad?
Well, that's a good question. I mean, I remember when I cut myself open here, it was my father, no longer with us, but his 90th birthday, and I was carrying this tray across, and I tripped over a footing in the ground, and this tray cut in my hand. I had 35 stitches here, and for 3 or 4 years, it was painful because scar tissue hurts. There's a lot of nerve endings in fibrous scar tissue. So I think that fibrosis, when the scar tissue is formed there, has a lot of nerves that are involved, not a lot of nerve supply in scar tissue.
I agree with that. If you look at the number of pain receptors in fascia or connective tissue compared to muscle, there's 6 to 7 times more pain receptors in connective tissue. So when you have a fasciitis, an inflammation of your connective tissue, it's gonna hurt. And if you rub along your IT band, if you're listening and you have lipedema
Yeah.
and you feel nodules along your IT band, that's a fasciitis. And it's often very tender. And I can take my finger and just go like this. And, my patients are like, yeah, 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 that hurts.
But see, you use the word fasciitis, which means it's kind of an inflammatory process. But I think at some point, like now, after 15 years, there's no more pain there. So maybe that goes on for a period of time, the first few years, the pain, and at some point after it's kind of like burned itself out, and the pain tends to go down. I think in patients we see that are maybe more end stage with lipolymphedema, where it's just like old scar tissue, old
Yep.
20 years old, they're probably not having pain in those areas because it's kind of burnt itself out and just formed old dead scar tissue like this over here.
Yeah, Linda and Khan just mentioned that there's millions of nerves in fascia. And we published a paper, gosh, a long time ago, looking at the different stages of lipedema. And we found that the women with stage 3 lipedema had numbness in their legs. And that's exactly what you're talking about, David.
Mm, mm, mm.
So this is an unusual question. This is from Sarah. I don't want to say it wrong, but Alalawi. And she says, Dr. David, I have lipedema and I'd like to ask something based on your dermatology expertise. I often get small red dots under my skin, especially in the lower body. They usually appear after any physical effort, even light activity, and fade within a few days to a week. But sometimes they show up without exertion and can stay for weeks. Could this be related to lipedema?
Uh, I don't know. I don't know. I mean, maybe, it'd be kind of, listen, I'm a derm, so we like to look at things visually, and I don't have a really good visual of this thing. Small red dots on the skin that
Could it
last
be petechiae? Just petechiae?
maybe they're small petechiae, possibly. Petechiae are a little more kind of a purplish color with things like that, but maybe they're petechiae.
Yeah, maybe it's like
It's
I don't know, an angiogenesis. I gotta say this. I gotta come back to this because I want your expertise on that. You were talking about and this is kind of onto her question, that dermal hypodermal junction. And I got really excited about it because that is a very unusual spot in the body for two completely different tissues to come together, the
mm-hmm,
dermis and
mm-hmm,
fat. And
mm-hmm,
so I thought,
mm-hmm,
oh, I'm sure somebody studied that
mm.
and, the exact structure of that. And I went into the literature, and the only thing I could find is, yep, there's a lot of lymphatics there. And yep, there's a lot of blood vessels there, but that's
Yeah.
it, nothing else. And I was thinking, like you're thinking, that there's some sort of connective tissue issue, and it allows the dermis to kind of pull away from the fat underneath, which would allow fluid and fat cells to go in there. So
Oh,
where
interesting.
is the data on that region of the body?
That's a really interesting thing you just mentioned. I don't know. I was thinking what's going on at that junction is um there's a lot of lymphatic capillaries there.
Yes.
And those lymphatic capillaries are leaking as part of the condition of lipedema. I remember Feldy, we talked somewhere in New York or something like that, was saying, the lymphatic capillaries are really in that subdermal layer there. So I just thought in certain patients, that's where a lot of the leakiness is going on, and the inflammation, the granular fibrosis. And that's why, I'll say this, I was in Germany we were in Germany at a conference a couple of years ago, and we're going to Rome in a couple months from now. And somebody was talking about liposuction for lipedema and saying that you've got to stay 1 centimeter below the skin. You should never go less than 1 centimeter. And I'm like sitting in the audience quietly thinking, no, 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 no. You really have to, in many patients, actually be more superficial with it in the right type of way, because a lot of these patients have that subdermal fibrosis. And if you don't do it properly with it, you're not removing the fibrosis there with it.
Hmm.
You really need to with it. But there's concern that you're damaging the lymphatic capillaries with it.
Yeah.
But the lymphatic capillaries will regenerate with things. Like
Yes.
if you what you don't want to do is damage the deeper lymphatic branch, the trunks, which don't exist in that subcutaneous plane as much. They're underneath the fascia.
Yes. Yep. Yeah. I'm not a surgeon, but I'm going to take your word for it. And I've seen, liposuctions where you can actually see the cannula tenting the skin.
Uh, did I lose you, Karen? You
She did freeze for just a moment, and it's a perfect time for
tapped.
you to freeze because we are running out of time, which is so crazy.
And the sun is getting more and more direct. So thank goodness you jumped in, Brenda.
I want to thank you both for this riveting conversation. We still have 30 questions in the Q&A that we
Uh,
didn't get to, which means that this is a topic that's so important. It's resonating with both the clinicians that have logged on and the patients. Dr. Amron, thank you so much for your time. And I want
Thank
to
you so
just call
much.
back to something you said. You said it's a really cool time to be focusing on this. Could you leave us with some inspiration on that? And then I'll leave it to you, Dr. Herbst, to close us out.
Well, it's the inspiration was, I just, I've said this, we go into medicine to help people, and we like science, and I feel so blessed truly to be part of caring for patients, and me and Karen being part of being in the frontier of what we're learning about lipedema and researching on lipedema and therapeutically making advances for lipedema. It's just an amazing, amazing time. and be involved in educating others and healthcare professionals. And we're going to build upon that. A little plug for Lipedema Society, which we've begun as being a significant medical society for lipedema. Karen and I are going to do great work in terms of advancing things for lipedema.
I love it. Thank you so much. Dr. Herbst, how would you like to close us out?
Can you still hear me?
Yes.
Yep.
Okay, because you guys sound like a tin can, so I'm having some technical difficulties. But David, I want to say thank you so much for tonight. You have such great insight into lipedema, the lipedema process, and I really
Yeah.
want to tap into your fibrosis patterns and see if we can't make that into a reality, because I think that's going to help us understand the pathophysiology of lipedema better. So thank you, and thank you, Brenda, for hosting.
And
And thank you, Lympha Press, for
Yeah.
allowing us to have this webinar.
Thank you, Brenda. Thank you, Lympha Press. And I got to Karen, you are a great host. You really are.
I know, she really
You were
is.
so good.
I know. It was a great night. And we just love all the chatters too. Heart bows to the chatters that were so engaged and putting their questions in the Q&A. We appreciate you. Lympha Press appreciates you. And when we're talking fibrosis, when we're talking lymphedema or lipedema, and you're not using a Lympha Press or using it in your practice, please reach out to us, lymphapress.com. We'd be honored to help. And we're honored to work with the leading minds that are helping patients improve their lives. Have a great night, everybody. We'll see you next month.
Thank you. Good night.
Bye.